Thank you very much, Valerie. Our final speaker is Nadine Burke Harris.
Good afternoon. It's my pleasure to be here, and certainly an honor to be part of such a distinguished panel. I'm going to talk a little bit about the implications of ACEs in clinical practice and policy, and I'm so glad to be going after Valerie, who did such a wonderful overview of the Adverse Childhood Experiences Study. I am not a mental health practitioner. I'm a pediatrician. I'm a primary care pediatrician. I have a background in public health. And how I got into this work and the issue of child trauma was when I finished my residency at Stanford, I wanted to work in a place where I was really needed. And so I came here to San Francisco and was hired by California Pacific Medical Center and to create programs to address health disparities. And so when I looked at the data, there was one neighborhood here in San Francisco that is the Bayview Hunters Point neighborhood that had some really awful health disparities. And I said, okay, great, I'm going to go there, I'm going to open a clinic, and we're going to bring best practices, and we're going to get rid of all these health disparities, and it's going to be great. And so that's what I did. And in the process of doing the groundwork to be able to open the clinic and get families to come in and trust us and trust that we were really going to do a good job, I went to schools and after-school programs and churches and daycare programs, and I said to all these folks, hey, we're here, we're opening a clinic, send us your kids, tell us what you need, tell us, you let us know, we're here to serve you. And in doing that process, we developed a tremendous amount of rapport with the community so that when we opened our doors, they did exactly what we had asked, and they sent us their kids. And they said, Dr. Burke, can you take care of Bobby? Bobby's got terrible ADHD. Dr. Burke, can you take care of Susie? She can't sit still in class. She's constantly falling out. She's got ADHD. Can you put her on some Ritalin? And so I did my job, and I said, yeah, send them to me. I'll take care of these kids. And when I did my job and did a thorough history and physical, it turns out that the vast majority of these kids did not have ADHD. The stories that I heard from these kids and their caregivers are very similar to the story that we heard from Tonia earlier. In fact, when I was listening to her story, I'm sure, like you, it touched me very deeply because I could see her as that 9-year-old girl. And I've seen that girl in my clinic hundreds of times. And so when I have a kid who's falling out in class, who can't learn, who's not paying attention, or who's having a number of physical problems that it's really difficult to nail down, when I started looking, so, as a physician, if I were working in a neighborhood and 40% of my kids had tuberculosis, I'd, pull out all my reference materials and find out about tuberculosis. If my kids were suffering from cancer or autism or HIV, I would become an expert on that. My kids were suffering from household dysfunction, parental mental illness, parental incarceration, community violence. And so I decided to look into the literature and figure out how is this affecting our kids. And that's when I came across the ACEs study. And the way the clinic works, when we set it up, we have, I was a pediatrician, but we also had a case manager and a psychologist, because we felt like all of those were necessary in the primary care home. And we worked together to take care of these kids. And one day my psychologist brought me this paper, and it was the original ACEs study that was published in, I believe it was 1998. And at that moment, everything just clicked for me. Because not only were all of my kids at higher risk for behavioral problems, getting held back in school, if they were getting held back in school, but many of them had the same experience that Tonier had of being passed on, which I feel is almost even worse. Because the neglect is not just the individual neglect that happens in the household, it's the systemic neglect that happens in the community of people that is set up to allow these things to happen. Because nobody wants to put the effort in to do what's necessary to actually heal these children and families. And so when I saw that these exposures that my kids were having were not only increasing their risk for all of these adverse social and behavioral outcomes, but we're also increasing their risk of hepatitis, as we see the relative risk of when we saw the dose-response relationship between ACEs and all of these organic diseases as well, hepatitis, sexually transmitted infections, chronic obstructive pulmonary disease, as well as the mental health outcomes, depression, suicidality, and the behavioral health outcomes, IV drug use. All of a sudden, I recognized that it was my responsibility as a pediatrician that if I wanted my teenager not to get pregnant, or in this, one of the things that was looked at was fetal death in pregnant teens. If you were a teenager, what was your risk of miscarrying? If you had 4 or more ACEs, your risk of miscarriage was almost double than if you had no ACEs. And if you had 7 or more ACEs, your risk of ischemic heart disease, the #1 killer in the United States of America, was 360%. Now, here's the thing. As a doctor, I go to the doctor. And every time I go to the doctor, they check my heart rate, they check my blood pressure, they check my cholesterol. But if you have 7 or more ACEs, your relative risk of ischemic heart disease is higher than if you smoke, than if you have high blood pressure, or than if you have high cholesterol. But no doctor that I've ever been to has ever asked me about any of those things. And so I really felt that it was my responsibility to start doing this work. One of the things that I immediately looked at was, how does this happen? So it's important to know that it happens, but I'll tell you, after doing 4 years of medical school, a public health degree, and a pediatrics residency, I am so tired of hearing that if you are poor, you got worse health outcomes. If you're a person of color, you got worse health outcomes. If you're a recent immigrant, you got worse health outcomes. We know that. My family immigrated to Palo Alto from Jamaica. Shout out, Yardies. When I was 4 years old. I don't need research to tell me that if you're a poor black immigrant, you got worse health outcomes. What I need to know is why and how do we target it? If you are a white woman living in Marin County, you have one of the highest breast cancer rates in the United States. And guess what? Everybody wants to know why, because it doesn't meet anybody's expectations. It must be something going on. Why is it? Is it something in the water? Does it have to do with the diet? What's going on? But when you have poor black children living in the hood who grow up to have the worst health outcomes, nobody asks why. I want to know the mechanism. I want to know the biochemistry behind it. And that is what we began to look at. We understand that the exposure to trauma beginning in infancy and childhood triggers the fight or flight system, the hypothalamic pituitary adrenal axis. And when that happens repeatedly over and over again, particularly with the traumatic stress, there's a number of things. It causes dysregulation of your hypothalamic pituitary axis. It causes dysregulation of the reward center of your brain, the ventral tegmental area of your nucleus accumbens. It causes toxicity to your hippocampal neurons. Your hippocampus is the area of the brain that's associated with memory and learning. It causes dysregulation of your neurotransmitters and of your receptors. But guess what? So that, for me, explained a lot of the behavioral problems that I was seeing in the kids that I was caring for in my clinic. So yes, we know that if you have 7 or more ACEs, you're 360% as likely to have ischemic heart disease. But guess what? Even if you don't drink, don't smoke, don't engage in high-risk behaviors, your risk is still elevated, because the physiologic experience of what happens in your body just by being exposed to adverse childhood experiences triggers also a cascade of immunologic problems. So you're walking in the forest, you see the bear, you're either going to fight the bear or run from the bear, that fight or flight system. But your immune system figures, hey, if you're seeing a bear, you may take some licks. And it stimulates inflammation in your body. When adrenaline goes off, that stimulates inflammation. And so when you have chronic firing of your fight or flight system, you also have chronic inflammation. And that's why a lot of the diseases that we see associated with adverse childhood experiences are chronic obstructive pulmonary disease, hepatitis, ischemic heart disease. A lot of these, exposure to trauma is a problem of chronic inflammation as well as neurologic, immunologic, and endocrine dysregulation. And we can see that by the fact that adults who were exposed to trauma in childhood have increased markers of inflammation in their blood, such as interleukins, tumor necrosis factor alpha, and interferon gamma. From a hormonal standpoint, we also see that chronic dysregulation. Adult adrenal corticotropic hormone and plasma cortisol levels, these are hormones that are exposed to that are associated with a stress response, correlate directly with adverse childhood events, neglect, and depression measures. And maltreated children with PTSD were found to be excreting higher than normal cortisol, so long-term stress hormone, and adrenaline, short-term stress hormone compounds in their urine years after disclosure of abuse. Similarly, when we were talking about, we heard from Alicia about the impacts on the fetus when there's domestic violence in the household. Starting from the prenatal period and moving throughout childhood, exposure to chronic stress affects the way our DNA is read, the way our DNA is transcribed. It's called epigenetic regulation. The way, when you look at adults who are exposed to trauma as children, you see differential gene expression of pro-inflammatory, so it increases your inflammation, right? It increases transcription of all those inflammatory markers. And the other thing is that it causes epigenetic modifications leading to decreased glucocorticoid receptors in your brain that causes increased dysregulation of your hypothalamic pituitary adrenal axis. So again, your HPA axis goes out of whack. So if we want to understand, so in my mind, when I hear Tonier's story, and I hear the story of kids in my clinic, and we are asking, we as providers are looking at folks and say, why do people make the choices that they make? And Tonier talks about why she made the choices that she makes. There's another piece of it. Your impulse control is affected by the process. It doesn't matter how much you want to do the right thing. We heard how much people want to do the right thing. Your self-regulation processes in your brain, your prefrontal cortex, all of these things are affected. And so when we look at what we have to do to effectively deal with the issue of adverse childhood experiences, we know that the scope of the challenge is large. And from that perspective, we know that a public health approach is necessary, because the impacts are pervasive and long-lasting, and they have to do, we know that they have health impacts, health and well-being, mental health, behavioral health. The social impacts are tremendous in terms of education, learning, incarceration. The economic impacts. One of the things that I'm most interested in is to see a study that fully documents the economic impacts between how much money we're spending on treating heart disease, COPD, hepatitis, lost productivity, mental health treatment, prescription drug benefit. We spend 18% of our gross domestic product on health care. Now, even if you don't care about people's health and well-being, even if you don't care about mental health, even if you don't care about children, if you care about the competitiveness of our nation, if you care about not spending, if you care about the debt, if you care about not spending 18% of our gross domestic product on health care, you should be an advocate for addressing adverse childhood experiences early and effectively, because the prevalence is high. In the ACEs study, we found that between roughly about 12.5% of folks reported an ACEs score of 4 or more. When I do the screening in my clinic and I see a child, I use the form that I downloaded from the CDC website, and I do the screening for my patients. I screen every single one of my patients, and I know that if that score is 4 or more, that child is 2.5 times as likely to develop COPD. They're 240% as likely to develop hepatitis. They're 4.5 times as likely to be depressed. They're 12 times as likely to commit suicide or attempt suicide. And I know where to direct my resources in terms of preventive counseling, in terms of interventions, in terms of support for those children and families. The evidence is strong, and we also know that early interventions improve outcomes. There is no better setup for a public health intervention than this issue of adverse childhood experiences. So what does that mean? Well, we got to take it on a couple of different approaches. Number one is awareness and advocacy. We have to raise awareness among the community, among practitioners, among policymakers, researchers, and funders. This is a forum for mental health. I'm a pediatrician. But we really have to develop therapies and develop treatment protocols that go outside of the scope of our own scope of practice. Our clinical protocols need to be multidisciplinary and multimodal. We need to have collaboration and integration of services. And we have the big thing, and one thing I'm going to say in a second, is infrastructure. We have to create a treatment infrastructure that allows someone like me to screen a child in primary care and make sure they're plugged in to get all of the services that they need so that we can effectively improve outcomes. And then finally, from the standpoint of policy intervention, there are a couple different levels where we can do policy intervention. Number one, on the level of professional groups, I sit on a task force for the American Academy of Pediatrics addressing violence and child maltreatment, and what is the American Academy of Pediatrics policy recommendation going to be. We need to take local, state, and federal action to protect children, and that includes legislation to do a number of things, to free up some money and some resources so that we can create this infrastructure. Before any one of my kids can get into kindergarten, they have to have all their vaccines, right? Anyone, 4-year-old wants to go to kindergarten, they got to get all their vaccines. I have treated a couple of cases of pertussis, but I'll tell you, I haven't treated one case of tetanus, not one case of diphtheria. That's not what's killing our kids. What if we had a law that said, in order to get into kindergarten, every child has to be screened for adverse childhood experiences? That'd be crazy. I mean, I think that's what needs to happen. And I think that if we had the combination between the appropriate policy support, legislative support, and a treatment infrastructure, because the challenge is no one's going to screen if they're left with this big mess on their lap that they don't know what to deal with, right? So we have to have the infrastructure. Just like right now, if I have a child that's diagnosed with diabetes, I send them to an endocrinologist. So if I have a child and they've got 4 ACEs, what do I do? Who do I refer them to? Because their problems are not just behavioral. They're behavioral, they're psychological and psychiatric, they're educational. They have a harder time learning in class. They're physical, right? So really developing that infrastructure is extremely important. Just in terms of my own practice, what we've done is just develop a protocol. We screen every single child for ACEs. If their score is 0, great. If their score is 1 to 3 and they have symptoms, we refer them to multidisciplinary rounds. If their score is 4 or more, regardless of whether they have symptoms, we also refer them to multidisciplinary rounds. In our clinic, multidisciplinary rounds includes our medical practitioners, our pediatricians, our mental health practitioners, including some folks from Dr. Lieberman's team from the Child Trauma Research Project, our case manager, and our receptionist. The reason we add our receptionist is because there's a screening in primary care is different from treating someone who walks in your door into a mental health clinic. The reason is because there's a very different state of readiness. When we're screening in primary care, a lot of folks don't want us to know what's going on at home, and they're not interested in pursuing services quite yet. They're not ready yet. It may take a while, a little bit of teaching and education about the potential to heal and the opportunity to make things better. We may have to develop some trust in the primary care home before they take advantage of the resources. But part of the reason we include our receptionists is because maybe we referred them to services and they didn't go. But the next time that kid calls in, the mom calls in for an ear infection or for strep throat or to get a school form, that receptionist, we have a list, and our receptionist knows, oh, get this family into the clinic, right? So we really take an ecological approach. Our multidisciplinary treatment methodologies include trauma-informed medical care, psychiatric and psychological services, case management, educational advocacy. That's a huge thing. We did a chart review of the 700 patient charts that we saw in the first 2 years of opening the clinic. For kids who had an ACEs score of 4 or more, they were more than 30 times as likely to have learning or behavior problems in school. So school failure is oftentimes a presenting symptom, where people won't say, hey, I'm being beaten and raped at home, but what they do say is, Susie can't sit still in class. So educational advocacy is a huge piece. Integration of evidence-based supplemental therapies, which include mindfulness-based awareness and biofeedback, which also addresses some of the somatic or physical modalities that are affected. And then, of course, long-term follow-up. Part of the reason that I advocate screening in primary care is because when I'm someone's pediatrician, it's from birth until 18 or 20, or some don't want to leave the nest at 22. But we can do long-term follow-up, and that's very important because we know that the effects of ACEs are not going to resolve in 10 weeks or 12 weeks. It takes a long time. We're in the process of, in order to be able to do all of that full scope of multimodal therapies, I actually have just left my one baby to birth another baby. I left my role as the medical director of the Bayview Child Health Center, where I'm still seeing patients 1 day a week, to create the Center for Youth Wellness, which is really a place where we can do all of these things. It's a center where we can have pediatric care, case management, mental health, community health and wellness services, and also integrated with research and training to track these outcomes and figure out which of these interventions are most effective. And it's also a place where the community can come and learn about adverse childhood experiences. When I talk to my families, I don't talk to them about trauma, I talk to them about drama, right? Because it's not, for a lot of families, it's just how it is. And so really being able to do that work on the community level in a way that is effective in making a difference for vulnerable families, that's what we're all about. Like I said, the next step is really building infrastructure. We have the data, we know what's effective, we just need the infrastructure to be able to address this on a systemic level. Thank you.
I want to really thank all of our panelists for their very informative and very powerful and compelling presentations. I'm going to have Fran come up now and give you directions for the next part of the meeting. Thank you.
I actually wish we had more time to actually ask questions, and I'm just very pleased that we have videotaped this, because I think this panel was a very powerful, very educated panel, and I'm hoping that once we put this on the website that we can actually pass it on to our colleagues so that they can see and get some sense of what we just experienced.